And this is a 30-minute session, the Indian scenario. We'll be talking about helminthiasis, Kala Azar, leprosy, and melioidosis. The session would be taken by Dr. Rita Prata Kundu. The CVs are there in front of your screen. Sir? I'm so sorry. I'm so sorry. The next session is the new diagnostic modalities for tuberculosis beyond NTEP and extrapulmonary tuberculosis, and the speaker is Dr. Ankit Parakh. Dr. Ankit, please welcome, sir. And the session would be chaired, and panelist would be Dr. Varinder Singh. Sir, we welcome you. We will be taking benefit of your knowledge once again, sir. Dr. Sangeeta Sharma, ma'am. Dr. Kamal Singhal, sir. We welcome on the stage, sir. And Dr. Sangeeta Makar would be chairing the session. And Dr. Pankaj Paul from Jalandhar. Please welcome, sir, on the stage.
So, a very good afternoon to everyone, and thanks to the organizing committee for keeping this topic and inviting all of us for the seminar. So, for today's panel, we have three well-known panelists, Professor Varinder Singh, who is the chair of the NTP, the pediatric section. We have Dr. Sangeeta Sharma from the LRS or the NITRD, and Dr. Kamal Singhal from Lady Hardinge Medical College. Right, so what we'll try and do in the next 40 minutes is take you through what is available to us as of now, and that's important to understand because there's always a mixed audience who may not be really aware of what has gone through the NTEP. So what are we doing as of now? And we'll take you through some recent developments which are happening, and things might change in future. Now, there is a paradigm shift from something known as TB control, which we were looking at previously. We were trying to reduce the number of sputum smear positive cases way back, and we have moved to a TB elimination, or we are moving towards a TB elimination where TB ceases to be a public health problem. It is not possible to achieve a TB eradication, but if we can achieve an elimination where the cases are something like less than 1 million, then definitely it ceases to be a public health problem, and that is the end game of tuberculosis. Now, looking at this, these were the goals which were set by the WHO, which started from 2015, and as you can see, this is what was projected to be achieved. So a 20% reduction, 50%, 80% and 90% reduction. If you look at the left graph, this is talking about the cases per year. And then it used to talk about the deaths. So there should be a 35% reduction by 2020, 75% by 25, 90% by 2030. So this is what was projected. And the Honorable Prime Minister said that we want to achieve these targets 5 years ahead of the global TB targets. This is the situation as of now throughout the world, and as you can see, India falls into a large, or India harbors a large chunk of TB patients. So India and the neighboring countries like Pakistan, Bangladesh, China, Philippines and Indonesia, these are the main countries, 5 main countries where the largest incidence of tuberculosis is still there. Now, what have we achieved till now And this global tuberculosis report published in 2024 talks about an 8.3% reduction in the incidence of tuberculosis, right? So that is what we have achieved, right? We have achieved a 23% reduction in mortality and a 49% reduction in the catastrophic cost, and which is way behind the targets which we had actually initially thought we could do. And similar is the Indian data. So this is from the WHO TB report in 2024, which again talks about 217 per lakh population cases. They have been reduced to 199 and the target was 77. And again, as you can see, the mortality was around 32 per lakh population. It has reduced to 23, but the targets were 6. So there is still a long way to go. And that brings us to this, which is the NTEP, or the National TB Elimination Program, which has 3 pillars: prevention, detection, and treatment. And there's a large base which is formed by the Ministry of Health, and there are a lot of things which are done which not directly, they do not directly implies to doctors, but that is more of the managerial part and the political part. So these 3 pillars are there, and today we'll discuss about the detection part for this meeting, right? So the diagnostic tools for childhood tuberculosis, we all know, these are the main 3 things which we follow: a good history and examination, radiology, and bacteriology. And as you see, as we have gone along, bacteriology has become more and more important. And we are looking for a microbiological diagnosis in all patients. And this is the entry point for the algorithm. So persistent unexplained fever, a persistent cough, a definite weight loss, or failure to thrive. So if a child has these symptoms, then this is possibly a child who has presumptive tuberculosis. Previously we used to call it as a TB suspect. And then you need to evaluate this child for tuberculosis, right? So let's go on with this background. Let's go on with this case. So this is a 12 years old girl who presents to us with a 3-week history of documented fever. She has coughed for 2 weeks and she has lost 2 kgs weight. Her initial weight was around 68. She hasn't been treated ever for tuberculosis. There's a contact in the family. So the chacha has pulmonary cox. This is what we know. She already has received a course of Comoxiclair for the past 10 days, and which hasn't changed any of her symptoms. Right, so the treating pediatrician gets a CT scan of the chest. So let's bring in Dr. Kamal here and ask him about his comments on this case. So with this background of fever, cough, weight loss in a 12 years old child with some history of contact with tuberculosis, you have an X-ray here and you have a CT here. So what are you thinking about, sir, and how would you go about this case now?
Thank you, Dr. Ankit. So what we have here is a history which is subacute and fairly prolonged. So that is something that takes you towards tuberculosis. That when you have a subacute onset illness which is going on for 2-3 weeks, this is where you start thinking in terms of tuberculosis. And then we look at history of contact. Now in this particular case, it is important that it is not just enough that does she have a pulmonary TB contact around. We should know whether that contact has responded appropriately to the drugs that he's been taking. If the contact has not responded well, is on drug-resistant TB, then upfront, from a presumptive TB, we move on to a presumptive MDR. So on history itself, you should start thinking in those terms that the history is suggestive of presumptive TB. But if you have a contact who has not responded to therapy or who is on MDR therapy, then he becomes an MDR suspect. Now, add a bit of radiology to this. If you look at this radiograph, it has some infiltrates. If you look at the chest radiograph, there is retrocardiac infiltrate that you can see on the radiograph. So there are some things on radiography which we say are highly suggestive of tuberculosis. And in other words, there are some things on radiograph which can be highly suggestive, but it is important to know that none of them is diagnostic and none of them can say surely that this is TB. So all this is suggestive, but it cannot confirm. If you look at this particular radiograph, it has some infiltrates in the retrocardiac zone, so it's some kind of pneumonia there. But then this alone will not make it TB.
Okay, so what would be the next investigation which you would do?
So in such a child where you have parenchymal involvement, the respiratory specimen is to be sent. So we would preferably send a sputum for a cartridge-based CB NAT as well as MJIT in this child. So this is an initial step to begin with, that a sputum is to be sent. If of course sputum is not available, then a gastric aspirate is to be sent.
So I think that's the first message which everyone should remember, that in situations when you have a presumptive tuberculosis, don't forget to send a sputum sample, right? So a lot of people still don't send sputum samples. It is very important, and if the child cannot produce a sputum, then we have alternate samples. Okay, so this child's sputum is negative. So my question to you is that with this background of a possible contact with a presumptive tuberculosis, are you happy to say or happy to start this child on treatment?
So of course he will be started on treatment. The question is TB. So given this history and adding a bit of what I'm just re-emphasizing what Dr. Pankaj said, that he has taken a set of antibiotics to which he has not responded. So that cycle is important. It could be a pneumonia which could very well respond to an antibiotic. So if the child has taken that course of antibiotics, as you said, he has received amoxicillin plus clavulanic acid, and after that there is no response. So the caveat here is that you should give your best in terms